Hello, and thank you for taking the time out of your evening to join us for this Introduction to IVF webinar with Dr. Alison Richardson. Following the presentation, Dr. Richardson will be responding to your questions. You can submit these at any time during this evening's webinar via the Q&A panel on the right-hand side of your screen. I will now hand over to Dr. Alison Richardson.
Hi, thanks Sam, and thank you all for joining us this evening. We've just put together a presentation for you on a treatment that we offer at Care Fertility, and I'll go through that. And as Sam said, if you've got any questions, please feel free to send them through in the chat. So welcome to Care. We have got lots of clinics all over the country. We've also got some clinics in Spain and America. So wherever you are in the country, hopefully you're not too far away from one of our clinics. The other sort of beautiful thing about Care is that since the pandemic, we've been doing lots more remotely and virtually. So even if you do live a bit further away from one of the clinics, you can have all your consultations and things done virtually, so you wouldn't have to travel to the clinic too often if it is a long way away from you. We also have some satellite clinics which offer parts of the treatment, so like clinic appointments and scans and things, but they don't have labs, so you couldn't have your egg collection or embryo transfer in those satellite clinics. You'd have to travel to a main clinic for those ones, but again, generally most people live within not too far from one of the main clinics. So before we can start any treatment, we need to make sure that we are recommending the right treatment for you. So I think a lot of people get confused with the different treatments that there are for different aspects of infertility, and although we may recommend IVF to lots of different people with different problems, sometimes alternative treatments may be better suited for you. So there's things like ovulation induction and IUI, which are a bit different, and I'll go into those a bit at the end, but they may be appropriate in some situations, whereas IVF is appropriate in other situations. So in order for us to be able to provide you with the right treatment, we need to find out a little bit about you. So we'll ask you to complete a questionnaire with your medical history on, and you do that before you come for your consultation, and then also we would want you to have some investigations before you come for your first appointment with us, so that we know a little bit about you before we see you, so that we're not kind of wasting time having hypothetical discussions. We know what the situation is and what treatment you would benefit from. So those investigations for the women generally consist of an AMH blood test, which is a measure of your ovarian reserve, and also a pelvic ultrasound scan, which also gives us an idea. So we count the follicles on your ovaries on that scan, but we'll also look at your womb and your tubes and your ovaries in a bit more detail, so that we can identify any issues that might cause problems during the treatment or during a pregnancy. So things like polyps and fibroids, or big cysts on your ovaries, or swollen tubes, things like that, that it's important that we know about. And then for any male partners, we would need to do a semen analysis. I think Sam's got a lovely video of a semen analysis being done, which hopefully he can play in the background now. So when they do a semen analysis, they look at 3 different things. So the most important thing is the concentration, and that's just how many sperm there are in every mil of ejaculate that's produced. The next thing that they look at is the motility. So we know that not all sperm will be moving, and some sperm will move, but it will be swimming round and round in circles, which is normal, but it's not particularly helpful for trying to get you pregnant. So what we're most interested in is the proportion of sperm that is moving in what we call a progressive direction. And then the third thing that we look at is the morphology, and that's just the fancy word for saying what the sperm looks like. So once we've got the results of those 3 investigations, we'll have quite a good idea, combined with your history from the clinical questionnaire that you filled in, we'll have quite a good idea about what treatment you would benefit from, and then we can discuss that with you during your consultation. So consultations, like I said, they can be done remotely or they can be done face-to-face. It's whatever your preference is. If you're in a couple and you want to have treatment as a couple, we would want to see you both together, but obviously if you're not in a relationship and you're having treatment as a single person, then we'd obviously, you know, just expect to see you on your own. And that consultation is generally about 45 minutes, and so we're going through your history, going through your test results, talking through your treatment options, and then hopefully coming to a plan together that everybody's happy with. The IVF process itself is quite complex, and you know, obviously it's something that in the clinic we do all day every day, but obviously it's something that a lot of you have never been through before, and you may or may not know people that have gone through it with you, so we will explain it to you all in detail. But basically the way that I explain it to patients is, if you imagine that your ovaries look like a bunch of grapes, and each grape is a follicle, and inside each follicle is an egg, and the size of your bunch of grapes gets less as you get older, because women are born with all the eggs in their ovaries that they're ever going to have, and from the moment they're born until the moment they go through the menopause, that number gets less and less. Okay, so naturally what happens is your brain sends a hormone signal to one of those follicles and says, you are the chosen one. That follicle gets bigger and bigger and bigger and releases the egg. And that's the egg that could potentially get fertilized that month if you were having unprotected sex. Okay, but most women have more than one follicle. You know, young women might have 20 plus follicles in their ovaries, and the other follicles that month, if they're not the chosen one, they just shrivel up and dissolve and disintegrate, and the eggs that they contain are completely wasted. So what we try to do with IVF treatment is give you hormones to stimulate your ovaries so that all the follicles will get big all at the same time, so that we can then potentially get an egg from each follicle. So it's not witchcraft or wizardry or anything like that. All we're doing is trying to make use of eggs that would otherwise, for no good reason, go to waste. So that's kind of the rationale behind it. The hormones that we give you are exactly the same as what your hormones you produce naturally, but your body naturally just produces a teeny tiny amount of hormone because that's what it needs to stimulate one follicle, whereas we want to stimulate all the follicles, so we'll give you a much bigger dose of hormone. And those hormones are only available as an injection, and the nurses will teach you how to do those injections yourself. It sounds scary, and it is, you know, it's very daunting to inject yourself, but they are very superficial injections, so they just go underneath the surface of the skin. As you can see from the picture here on the right, the needle is quite small. It's not like in the movies where people having IVF, the needle's always like this big. It's really quite a shallow injection, and there's different treatment protocols, but generally it will be 1 or 2 injections a day, and you're normally on the injections for about 2 weeks, and during that 2 weeks you'd need to come into the clinic a couple of times for a scan so that we can monitor the growth of the follicles and make sure that they're growing nicely. Sometimes we need to adjust the dose of the medication that we've given you. Sometimes we need to tweak the approach. If you've got lots and lots of follicles developing, we change our approach slightly to make sure that we're keeping the treatment nice and safe for you. Once the scan shows that you've got a good number of follicles above a certain size, and that's usually after between 10 and 14 days, we will give you one last injection, which is called the trigger injection, and then no more injections. And then 36 hours later, you come into the clinic to have the egg collection procedure. So the egg collection procedure is done under sedation usually, so it's not a full-on anaesthetic, but it's quite nice. The anaesthetist will usually pop a drip in the back of your hand and give you some nice kind of gin and tonic flavoured medicine, and then most people just sleep throughout the procedure. They're not really aware of what's going on. Some people are a little bit aware of what's going on, but they're quite comfortable, and generally, even if they are aware of what's going on, they don't have any real recollection of it afterwards. But the way that they collect your eggs is with an internal scan, so very similar to all the scans that you would have had up until that point. This time there's a needle attached to the scan probe. They put the needle through the vagina into the follicles of the ovaries, suck out all the fluid that the follicles contain, and then give that fluid straight away to the embryologists. And they look at it under the microscope and count and collect the eggs for us. So it usually takes about 10 to 15 minutes. As soon as you wake up, we'll be able to tell you how many eggs we've collected, and then you'll go back to the ward to recover after the procedure. But most people usually go home within about an hour or an hour and a half after the procedure. We just recommend that you take it easy for the rest of the day, but then you'd be fine to go back to work the next day if you wanted to. Whilst you're having your eggs collected, if you're having treatment with a male partner, then that's when we would need them to produce the sperm sample. We can have sperm samples frozen in advance, so some people get quite anxious about doing the sperm sample. So if you think that that's you, then we will more than happily freeze some sperm, so that if there are any problems on the day, we've definitely got a sperm sample that we can thaw and use. If you're having treatment using donor sperm, then that's the day that we would thaw the donor sperm. And then in the afternoon of your egg collection, that is when we would mix the sperm and the eggs together to fertilise the eggs. And there are two different ways of fertilising eggs. So there is standard IVF, which is when basically, and please don't tell any embryologists that I've explained it like this, but basically they just mix the sperm and the eggs together in a dish, and the sperm still has to fertilise the eggs itself. So it's a little bit more natural, and we generally recommend IVF if the sperm sample is completely normal. So the concentration, the motility and the morphology are all completely normal. In those situations, we would recommend IVF. If we've got any concerns about the sperm at all, so if the concentration is reduced, if the motility is reduced, or if the morphology is very reduced, we would recommend doing something slightly different, and that is called ICSI, and that stands for intracytoplasmic sperm injection. I think Sam's got a video of that which he'll show for us. So this is when the embryologists will look at the sperm under the microscope, and they will pick sperm that looks good, and they will physically inject one sperm into the egg. Okay, so the embryologists are fertilizing the eggs, you know, on behalf of the sperm, and generally that's recommended when the sperm is not 100%. There might also be other situations when we recommend ICSI over IVF, but the consultant will go through that with you during the consultation, you know, which one they recommend for you. Once the eggs have been fertilised, so either with IVF or ICSI, they then get put into incubators for 5 days, and during that 5 days they are very busy multiplying and dividing and multiplying and dividing, and I always picture that 5 days as being a bit like a hurdles race. So each embryo has got to get over quite a few hurdles in order to get to day 5, which is the day that we normally recommend that they're transferred on. And we know that not every embryo that goes into the incubators will get to the end of that hurdles race. And that's why we've stimulated you to get as many eggs as we can, because we know that the numbers are going to get less as you go through the process. We have standard incubators at Care, but we also have our Care Maps incubators, and these are kind of fancy incubators in the sense that in a standard incubator we do need to disturb the embryos every so often to check on them, and every time we do that we have to take them out the incubators, look at them under the microscope, and then put them back in the incubators. And every time we do that, they're sort of taken out of their ideal environment. So although we try to keep it to a minimum, it is still necessary to do it a couple of times in that 5 days. Whereas in the Care Maps incubators, it is a closed system, so we never have to disturb the embryos. And the reason that we don't have to disturb them is because there's a camera inside the incubators that takes photos of the embryos every few minutes. And so when the embryologists need to do their checks, they don't need to take them out the incubators, they just need to look at the most recent photos. So I think Sam's got a video of the Care Map system, and it's really good as well, because every time something important happens, it will timestamp that, and then at the end of the 5 days it puts all that data into a fancy algorithm, and then at the end of the 5 days each embryo gets given a score out of 10, and we know that the embryo with the highest score is the one that is most likely going to result in a pregnancy. So it helps the embryologists choose which embryo to put back for you. So it really is amazing. And also, which is quite nice, it's not why we do it, but it's an added bonus, you will get the video of your embryo developing over that 5 days. So it's quite a nice kind of keepsake as well. So that is the Care Map. So that's optional. It's not, you know, it's not at all compulsory. It's an optional extra. But there is good evidence now that it does help improve success rates for people. Okay. The other thing that's optional that may be recommended to you, it's not necessary for a large proportion of women that are having treatments. We might suggest it if you've had lots of miscarriages previously, or if you've had lots of failed IVF treatment, or if you are slightly older and you're having IVF treatments. But that's something called PGTA, which stands for pre-implantation genetic testing for aneuploidy. You know why we have all these acronyms now, because the words are just too long to remember. So PGTA is like an extra step of part of the IVF process. So we still create the embryos, but when we look at embryos under the microscope or with the Care Maps incubators, all we can see is cells. We can't see inside the cells, so we can't see the chromosomes within the cells. And we know that as women get older, the eggs become sort of damaged as they get older, and if a damaged egg gets fertilized, it's likely to create an embryo that's got an abnormal number of chromosomes. And if an embryo's got too many or too few chromosomes, then it's less likely to implant, and if it does implant, it's more likely to miscarry. But we can't see that with the standard microscopes or the Care Maps. So if you wanted us to test your embryos to make sure that there's a normal number of chromosomes, then we would need to do the extra step of the PGTA. And what that means is that, so as I said, we collect the eggs, we fertilise them, we incubate them for 5 days. But on the 5th day, instead of having your embryo transfer, we would biopsy the embryo and we would remove a few cells from it, and we would send those cells to our lab in London where they would process it, and that's where they count the chromosomes. And then, so that takes 2 or 3 weeks for the results of that test to come back. So we'd need to freeze your embryos whilst we're waiting for that. And then at the end of that 2 or 3 weeks, we will get a result for each embryo. And if the embryo is normal, so if it contains the correct number of chromosomes, we would then tee you up to have a frozen cycle. If the embryo is abnormal, then we are not allowed to transfer abnormal embryos, nor would you really want us to, because the likelihood is that the treatment wouldn't work. So I think Sam's got a little video for PGTA as well. So this, you can see that they've drilled a little hole, and that sort of goo that's coming out is actually cells from the bit round the edge of the embryo, which is called the trophectoderm, and they're just very gently sucking up half a dozen of those cells, and they will send those cells off to the lab. That's it, that's separated away. So it's quite gentle, and yeah, that's PGTA. But it's, as I said, it's an optional extra. You know, it is recommended in certain situations, but it's not necessary for everyone. Sorry, there's just a question in a chat that's a bit relevant. So somebody's asked, if you don't want to have PGTA, are there any other ways that you can check for chromosomal disorders after pregnancy? Yes, there is. So sort of routine NHS antenatal care includes screening for chromosomal abnormalities. So when you go for your routine scan at 12 weeks, they will do a blood test, and they will also measure the thickness of the skin behind the baby's neck, which is called the nuchal translucency, and then they put all of that into an algorithm, and then that will give you a risk of your baby having a chromosomal abnormality like Down syndrome. The difficulty is at that point is you are already pregnant, whereas with the PGTA you get the result before you become pregnant. The other option, if you don't want to wait till 12 weeks to have the NHS screening, you can pay privately for a blood test, which is it's a free fetal DNA blood test. So for the women, it's just a normal blood test, but it's actually looking for DNA from the baby that's leaked into your circulation. So you can normally have that done, I think it's around about 7 or 8 weeks. We don't offer it at Care, but there are lots of places where you can get it done. But again, you're already pregnant at that point, whereas the benefit of PGTA is that you get the information before you get pregnant. Another relevant question in the chat is whether we would recommend PGTA for women over 40. Yes, it is something that we would start to recommend from late 30s onwards, just because we know that at that age the risk of chromosomal abnormalities gets higher. So it is something that you would perhaps want to consider at that point. The important thing with PGTA is it's not, it's a bit controversial. So some people think it's really brilliant, other people don't. The HFEA, which regulate all the fertility clinics, they have a traffic light system for all these add-ons, and they don't give PGTA a green light because it doesn't improve your live birth rate. And they're absolutely right, it does not improve your live birth rate, but what it does do is get you a live birth a bit quicker. So you know, and for some people that's advantageous. So I'll just move on from that. IVF process, so embryo freezing. So we would generally only recommend transferring a single embryo. There are a few situations where we might support you having 2 embryos transferred, but never any more than that. But if you've got any surplus embryos that are good quality, we would strongly suggest that you freeze those embryos. Freezing nowadays is really very effective. The processes that they use now are much better than they were, 15, 20 years ago. So the success rates between having fresh and frozen embryos transferred are virtually identical. Also the sort of in years gone by, we could freeze embryos, but the percentage that failed to thaw was quite high, whereas nowadays, again, because they've changed the way that they do it, the freeze thaw survival rate is much higher. So it really is a brilliant thing to do. And like I say, some people will have a fresh transfer but freeze surplus embryos. Other people are not ready to have a family right now, but they're anxious about their age, so they can come through and have treatment now to create embryos with no intention of getting pregnant for the foreseeable future, but they know that the embryos are there ready and waiting, so that when they want to have a family in the future, if they struggle to get pregnant naturally, they've got good embryos frozen there ready. We can also freeze eggs. So if you are not in a relationship, but again, you're anxious about your age, we can freeze eggs. So we put you through a similar IVF cycle. We stimulate you, we collect your eggs. Obviously, we don't fertilise the eggs, we just freeze them as eggs. And again, that's a much more effective treatment now than it was 10 years ago, just because the freezing and the thawing is so much better now. If you are having a fresh embryo transfer, or if you've frozen your embryos and you're coming back for a frozen cycle, the embryo transfer procedure is generally fairly simple and straightforward. It's a bit like having a smear test, so similar sort of position, similar equipment, similar sort of facial expressions, but we do it under ultrasound guidance, so it'll be a tummy ultrasound this time, and then we pass a very fine catheter through the neck of the womb. You can normally see it quite nicely on the ultrasound screen, and then when the catheter's in the right place, we inject the embryo. Usually just takes a few minutes. Your partners, if you've got one, will be allowed into theatre with you. It's not particularly romantic, but it's quite a nice day out, and then you go home and you twiddle your thumbs for 2 weeks, and at the end of that 2 weeks you will know whether the treatment has been successful or not. During that 2-week wait, all your injections will have stopped. The only medication that most people require during that 2 weeks is some hormone pessaries, so progesterone pessaries. They're like tiny tablets that go inside the vagina usually, and that's just to support the lining of the womb and encourage implantation, and then support the early pregnancy until the placenta takes over. So that is it. Oh, that's just showing the embryo transfer. That's it in a nutshell. Obviously, everybody is different. So if you have got friends that have been through IVF treatment, different people require different steps, and different clinics do things slightly differently. So it may not look exactly like I've said it will, but they're the sort of nuts and bolts of a very generic treatment cycle. As I said at the start, IVF might not be necessary for everybody. IUI is another treatment option that we offer at Care. It stands for intrauterine insemination. It's generally really quite good for couples that are, or individuals that are using donor sperm to achieve a pregnancy. It's generally better for younger women. The success rates aren't so good in older women, and basically that involves monitoring you in a natural cycle. So like I said at the start, imagine that one follicle getting bigger and bigger and bigger, and we will track that with ultrasound and by getting you to pee on some ovulation kits, and when it looks like you're about to release that egg, we would get you to come into the clinic. We would prepare the sperm sample, and then in a procedure that's very similar to the embryo transfer, so we pass a very fine catheter through the neck of the womb, but instead of injecting the embryo, we would inject the sperm. So for IUI to be most effective, you need to have a completely normal semen analysis. Ideally we need to know that your fallopian tubes are open, and there are tests that you can have that to confirm that your fallopian tubes are open, and you need to be ovulating. If you're not ovulating, sorry, that's just the fancy word for releasing an egg. So if you're not releasing an egg naturally, then we can give you medicine to make you release the egg, and that medicine is either a tablet, so something called letrozole or clomiphene, or we can give injections. So that's just a little bit on IUI. Shared motherhood is an option for women in same-sex relationships, and that is when we basically split the cycle. So we collect the eggs from one female partner, create embryos with donor sperm, and then transfer the embryo into the other female partner. So that's, you know, it's brilliant for some couples, and it's not necessary for other couples. Everybody's different, but we can support whatever your preferences are. Donation. So yeah, so at Care Fertility we have our own egg and sperm banks. We also partner with some other sperm banks, and you know, we don't really mind where you get your sperm from, and all egg and sperm donors are screened in the same way, and if you are moving forwards with treatment using donor gametes, then you would, part of the kind of pathway involves an appointment with someone from our donations team, and one of our counsellors, and they will go through the implications of that with you. But you know, it's very common for people to use donor sperm or donor eggs or both, or donor embryos. We can support that. We also it's more of the same. We also have a surrogacy team at Care that has won awards for being really good. So surrogacy is when you can't, for whatever reason, carry the pregnancy yourself. So it might be that the embryos are created using your eggs and your partner's sperm, or it might be that you're using donor eggs and your partner's sperm. And again, part of the process, if you do need to use a surrogate, is an appointment with the donations team to go through all of that with you in a lot more detail. I think that's mostly what I've said. So we know, as I said at the start, IVF treatment is physically, psychologically and financially exhausting, and we know that, and we do have lots of support available for you if you do have treatment with us at Care. So we have just introduced an app which is still a work in progress, in all honesty. So some of these functions are not available yet. I think mostly they're all there. It's just the medication reminders that isn't quite up and running yet. But that we've had really good feedback from that. And the plan in the not too distant future is for, like I say, your medication reminders to kind of ping up like a notification when it's time to take them. We also have some payment programs, so you can pay for your treatments as you go along, and that's absolutely fine. And we will give you cost estimates for the treatment that we've recommended, but we also now partner with Care Fertility, so there are payment programs that we have. So you pay a bit more upfront, but it guarantees you more treatments if the first cycle is unsuccessful without having to pay extra, or if the treatment is unsuccessful, then you the other option is that you have a refund. If you get to the end of your 2 or 3 cycles and you've not had a baby, then you'd get a percentage refund. We also have interest-free credit options available, so you can kind of pay in instalments. That's a relatively new thing, but it is it's available in all our clinics. At the moment, we are doing a special offer. So for just £449, you can have all those baseline investigations that I said at the start. So the ultrasound scan, the AMH blood test, and the semen analysis, and a consultation with the doctor. And that would all be included for £449. So I think that's running until the end of June. So if you are interested in that, then you need to get on and book that. I think Sam has got a link that you can click on if you're interested in that. And then, sorry, going back to support. So again, as I said, we've got the new app on the phone. We've also got our new patient inquiry team, who are amazing. They will be the people that you speak to when you first pick up the phone. And we have lots of information online. We have counsellors available should you need it. And we have our care pals, who are amazing, and lots of useful support on social media as well. So there's always someone there, even if it's the middle of the night. That there will always be something on social media, or you can send us a message if you're struggling. And I think that is the end of what I have to say to you. I think I've answered. Somebody's asked whether endometrioma's impact on egg collection. Yeah, endometriosis is a common reason why people might struggle to get pregnant, and some people with endometriosis have endometriotic cysts on their ovaries. They don't really impact on egg collection. Like, ideally, we would try to avoid the endometrioma during the egg collection procedure. Occasionally, it's not possible to avoid the endometrioma. And so if we did inadvertently puncture it, there's a slightly increased risk of infection, but we would routinely give you antibiotics to kind of cover you for that. But it doesn't happen very often, because we do it under ultrasound guidance. We normally know that it's there. Previously, we used to recommend that endometriomas be removed prior to starting IVF treatment, and if you've got a very big endometrioma, then we may still suggest that as an option. That's not something that we'd be able to do at Care. You'd need to have that done in the NHS or privately elsewhere. But nowadays there's more evidence to say that any surgery on your ovaries can reduce your ovarian reserve, so we're always a little bit more cautious now about advising surgery, especially when most of the time we can avoid the endometrioma. What other questions? Anything we can do to prevent ovarian hyperstimulation syndrome? Yes. So a complication, I guess one of the complications of IVF treatment is something called ovarian hyperstimulation syndrome, and this is some people are just more sensitive to the drugs, and it's generally the sort of people that are most at risk are very young women, very thin women, women that have got polycystic ovary syndrome, women that have got very high ovarian reserve. So we would pick that all up on our sort of baseline tests, and if we thought that you are at high risk of developing it, then we have a very specific treatment protocol that we put you on that minimises the risk. Even when we've minimised the risk with that specific treatment protocol, you may still develop it, and we in those situations we would recommend freezing all the embryos created, waiting for the OHSS to settle, which is usually relatively quickly if you haven't had an embryo transfer, and then once you've recovered, you know, the following month you'd then come through for a frozen cycle. So that is how we manage the risk of OHSS. Just scrolling through, somebody has just said that they have just had a molar pregnancy and whether there are any options. So generally, if you've just had one molar pregnancy, that wouldn't necessarily be an indication for IVF treatments. So molar pregnancies are strange phenomena. They're quite rare. If you've had you know, if you've had a molar pregnancy on a background of infertility or recurrent miscarriages, then yes, IVF treatment might be an option for you, and in those situations we would encourage PGTA in those situations to make sure that the embryo that we're putting back has got the correct number of chromosomes. So somebody else is saying what happens if you've got a good AMH but a low antral follicle count. What's good for some people might not be good for other people. It very much depends on your age. Normally the numbers are fairly similar. So when you come for your pre-treatment tests, the numbers for both are usually, you know, fairly similar, not identical. If there was a discrepancy at that point, we tend to kind of trust the AMH blood test result a little bit more than the follicle count, just because the follicle count is a bit more subjective, because, sorry, objective, because, no, I mean subjective, sorry, it's late, just because obviously it's a person doing a scan and there's limitations of anatomy and the scan equipment and things like that, whereas the blood test, you just take the blood sample and run it through the machine. So that's why we just tend to trust the AMH a little bit more. So we would tend to prescribe the dose more in keeping with the AMH rather than the AFC. Sometimes people might have a good follicle count, so they might have, you know, 15 follicles on scan, but when they start the treatment, it might be that only 4 or 5 of them respond to the treatment, and that, you know, sometimes does happen. They're not, you know, although we're trying to get all the follicles to respond, you know, sometimes some follicles just don't want to, and so they don't, and they stay small, and you might only get 4 or 5 that grow. But everybody fixates on number, but actually it's the quality of the eggs that is most important. So I would rather have a few good quality eggs than lots of less good quality eggs. So it is, you know, it is important to remember that, but I know it's really difficult because everybody fixates on number. If you have not responded as well as we expected in the treatment cycle, sometimes there is the option to increase the dose of the medication midway through the cycle, but that's not always helpful. But if you then needed to have another cycle in the future, we would start you on a higher dose of medication in the subsequent cycles. I hope that makes sense. I think that is most of the questions. I don't know if any more are coming through. Somebody's asked about assisted hatching. So assisted hatching, again, it's not something that is strongly recommended by the HFEA. It doesn't have a green traffic light. It is something that is offered in certain situations. Usually if you've had low fertilization rates with ICSI previously, it might be recommended. There is some evidence that it can improve fertilization, but there's also some evidence that it might increase miscarriage rates as well. So you know, there are lots of add-ons that are available. I like to think of them as bells and whistles. They are, you know, they're generally only recommended in certain situations, and that's not to say that you can't have them. You know, if you've read about it and you want it, then of course you can incorporate it into your treatment plan, but most of them are only really recommended in certain situations. But the consultants will go through that with you during that consultation at the start. Somebody has asked whether they can use a specific medication during IVF treatment. That will all be discussed with you during the consultation. So if anybody's on any existing medications, we need to make sure that they're not going to interact with the hormones that we give you. We also need to make sure that they're safe in pregnancy. So that will all be covered in that initial consultation. It may be if you're on medications that are not safe, or there's insufficient evidence, we might need you to switch to something that's safer, or stop it completely. And the same is true with non-prescribed medicine, so over-the-counter sort of supplements and things. They will go through all of that with you during the consultation about what we recommend and why. I think I have covered all the questions that have been forwarded on to me. So if you have got any others, speak now or forever hold your peace. But what's usually quite helpful is before you come for your initial consultation, we will bombard you with lots of information. So it's usually quite helpful if you've got questions to write them down and bring that list with you to the consultation. And most of the time we'll cover it all just with our normal kind of spiel, but if you've got any specific questions, then please come prepared. We like it. Oh, I've just had another one come through on the chat. What's the recommended gap in between IVF treatment if the first cycle is unsuccessful? So there isn't really any specific guidance on this. We always used to say 3 months, but I think that was very arbitrary, and you know, we can do it quicker. We do offer something called duo stim at Care, which is where we do 2 cycles back to back, so you don't have an embryo transfer, but we can stimulate you for 10 to 14 days, collect the eggs, and then within 5 days start another round of stimulation to collect another round of eggs. So we can do that close together. So it then seems silly saying we'll wait 3 months in between, but it is physically and psychologically draining. So most of the time people wouldn't want to go immediately. Again, you know, they'd probably want to wait a month or 2 in between cycles. PGTA for low morphology, is it recommended? No, so generally for low morphology, we might recommend ICSI, but we wouldn't necessarily recommend PGTA unless there was another reason for it. So PGTA generally, like I said, if you are over the age of about 37, 38, or if you've had failed cycles or several miscarriages previously, they would be the situations that we'd recommend PGTA. Oh, another question. If you've had lots of miscarriages and all the tests came back as normal, would you recommend IVF or trying naturally again? That's a really difficult one. I don't think there's any strong evidence either way. What we can do, so that the benefit of IVF treatments is that we can test the chromosomes in the embryos before we transfer them, and if normally the investigations that they do for recurrent miscarriage are on the male and female partners, they're not on the embryos. So even if all the investigations in you have both been fine, that doesn't mean that the embryos were chromosomally abnormal, and so we can test for that with the PGTA, but it is it is a difficult one, and there's two schools of thought really what the right option is, but you can always book a consultation and we can talk you through the pros and cons as both. Oh, you're all bringing them in now. Would you recommend varicocele treatment before IVF? So varicocele is like a varicose vein in the scrotum, and that can affect sperm parameters. They always used to, the guidance always used to be that they wouldn't operate on a varicocele just for purposes of fertility. They would treat it if it caused you pain or discomfort, but not just for a low sperm count. I think the guidance has now changed, and I think they can now offer varicocele treatment even if you haven't got any discomfort, but if your sperm is affected. I suppose the issue is that there's no guarantee that the treatment will be effective, and it depends what the sperm parameters are. We would probably still recommend ICSI anyway. So it's more if you are wanting to increase your chances of a spontaneous pregnancy rather than IVF treatment. Oh, another question. Does your chance of success reduce if you have mild endometriosis? No, it's not thought that if you have mild endometriosis that wouldn't affect your success rates of IVF treatment. So I'm going to give you all another minute to get your questions in. If you've sent questions and I haven't answered them, please don't be put off. Please just, like I said, bring them with you to your consultation, and your consultant will go through all of it with you in detail. I'm sorry if I've not answered everything, but I think I've answered most of the ones that have come to me, but please do make use of the deal for the reduced cost investigations and consultations, and hopefully we can support you all in your journey. And thank you for listening, and we may see some of you soon.